And now we're going to hear from Melissa Boudreault, who's the Vice President for Healthcare Reform at the Dell Perot Systems. And she was, prior to this job she's currently in, she was the Director of the Commonwealth Care, the Connector Health Insurance, and has had a lot of experience looking at financing and management and product development for all of healthcare systems. Melissa.
Small job. Yeah. Hi, everyone. How are you?
Good.
So before I start, I'm going to take the prerogative of having the lectern. Is Stephanie here yet? Would you stand up, please? So prior to coming to the Connector, I had done a lot of work within state government. And I have to say that being part of the Connector is probably one of the greatest privileges I've ever had. And I started in August of '06, and I left last November, and Commonwealth Care was affectionately known as my baby. It was very hard for me to leave. So I would like to introduce to all of you Stephanie Kroback, who has taken over the leadership for Commonwealth Care. Many of you will see her. I could not be happier. I feel like my baby's in good hands, and I was nervous about that. So Stephanie, welcome. This is part of the very large group that supports what we do. So thank you. Okay, so I'm going to resist the temptation to do a 45-minute overview on the Dell Perot suite of solutions for healthcare, and I want to talk to you a little bit about what's going on at the state level. There's two great things about being in the private sector again, and one of those is that I get to say what I think, which I didn't get to do for 3.5 years. So I'm going to talk to you a little bit about what I see happening in Massachusetts. Well, actually, that's not true. Brian knew a lot of what I thought, honestly, but that was always privately. I want to talk to you about what's going on at states, and I also want to talk to you a little bit about some of the lessons learned, because as I go out across the country, I realize that healthcare is so local, and the way it's delivered and the way people interact with the different healthcare systems, and I think that's going to be a challenge as we go at the federal level. Now, one of the bad things about being in the private sector is everything is done in PowerPoint. So I'm just going to talk to you tonight because I really don't like PowerPoint. So if you'll bear with me for a minute, I just want to give you a little bit of an introduction to, I think, what I took away and what many of us at the Connector took away in terms of lessons learned. So the Commonwealth Connector was really a petri dish for a lot of what was happening. It was very experimental, and transparency was very important to us. A lot of what we did was out in the public spotlight, and one of the first things that I will observe, and my colleagues have referred to, is that how things are perceived are often incorrect. So for example, last weekend there was an awful lot of discussion before the bill was signed, and I heard things that surprised me. I knew that I was going to hear that Massachusetts had blown the budget, but I heard people criticizing some really groundbreaking programs that had predated what we did in Massachusetts and were critical. Things like TennCare, which were described as a disaster because it couldn't be funded. But TennCare was one of the original programs that challenged the Medicaid model and said, how can we do this differently? How can we be more sustainable? The work that had been done in Maine. Maine's a small state. Maine does not have a lot of funding. And those folks up there have worked incredibly hard to try to build a sustainable public health and delivery infrastructure, and have often been criticized because they couldn't get people to sign up for their programs. So the first thing that I would observe, because many of you are in healthcare, is to continue to challenge what you hear and challenge the assumptions that people make. Because oftentimes the truth, the real accuracy of what's in there is somehow lost in the translation. I find that, I mentioned earlier, I speak nationally now, and when I talk to folks and I say, how many of you have heard that Massachusetts blew their budget? It's probably about 70–75% of the audience. And what I would also offer is that when we started this in 2006, it was all about coverage. And John Kingsdale used to say, we can't ask people to wait to get coverage until we can figure out the financing. Now, the world has changed, and the economy is different, but the initial healthcare reform, as Sarah pointed out, that wasn't about cost, that was about covering. The conversation has evolved, but I'm glad to see that a lot of the initial work that was done was still intact. So another thing to think about, what is healthcare reform? How do we define healthcare reform? One of the things I've seen as I've gone across the country, there's many different ways that people think about healthcare reform. One thing I would offer is that, in my mind, healthcare reform is about helping states and healthcare delivery systems make best use of what they have to serve their members. And that is a theme that I'll often come back to. At the end of the day, when we had a difficult issue we were trying to resolve, we always went back to what's best for the member, what's going to be best for the patient. And I really believe that if you keep that in mind, you'll never go wrong. Some of what's in the federal legislation does that, some of it does not. But we really need to think about what it is that we're trying to accomplish and the best way to get there in a sustainable model. Because if what we do now lasts 2 or 3 years, in my mind, we have not been successful. ComCare, in my mind, which was very successful, as you have seen at many levels, was not the success that it has to be if it's not here 20 years from now. And that's one of the things that, as we think about implementing national reform, I think we need to keep an eye on. Now, at the sort of more pragmatic level, some of the things that I hope we can continue that we started in Massachusetts in the States is a couple of notions. One is competition, and I know a lot of people kind of get uncomfortable about that, competition. Competition in the marketplace is critical. Now, one of the things that Medicare really suffers from, in my mind, and this is my opinion, is that there is a lack of competition among the providers. It's not a bad thing. Commonwealth Care was successful largely because we were able to generate competition among providers who care deeply about the populations that they covered. And in doing so, we're able to manage the cost and I think ultimately have a much better product for our members. Along with competition, I think another thing that folks have to really get comfortable embracing is the use of technology. Everything that is part of that national, so if you step back a little bit, there is, well, here, let me share this anecdote with you. I was in Washington a year and a half ago, and I was co-presenting with a woman who's passionate about medical home. She's very impressive. It was a pretty tough crowd, as crowds in DC usually tend to be. And a physician stood up and said, well, how is this going to work? Because all my medical records are on paper, and the only way this works is if they're shared. And she said, well, not to worry, because President Obama has put billions of dollars aside for health information exchange and a lot of electronic medical records, and everybody will have it, and then this will all work. And of course, the physicians in the room said, no, it's not going to work that way. But all kidding aside, we have to have the infrastructure in order to accomplish what we want to accomplish. Electronic medical records are critical. Health information exchange is also critical. Without those components working together, a lot of what we want to do is not going to be successful. Again, what's best for the patient? If the patient has the confidence and ability to know that their records are safe and secure, but managed in one place, it's going to make all the difference in the world. It's sort of a secret. I have this incredible deathly fear of hospitals, which is probably absurd for somebody who works in healthcare. But in any case, I was hospitalized last year, and I started with my initial physician, and she had this fantastic EMR. I was so excited. She did all the workup, and they sent me down to the ER, and the nurse started writing things down. And of course, I'm surprised they didn't throw me out. But I said, so where's all the electronic medical record technology from upstairs? And she said, well, the ER hasn't adopted that yet. As a patient at that time, never mind somebody who thinks a lot about these things, I found that frustrating. So we all have to challenge ourselves to embrace technology, embrace those changes, because it's really going to be critical as we go forth and try to make these changes. You've heard speakers say earlier, these are huge changes we're contemplating, and there's a lot of people who are dependent on us to try to get this right. So what's going on at the state level? It's pretty interesting. When I was in Massachusetts, I was probably in a little bit of a bubble. Getting out to talk to other states, it's very, very interesting how they view healthcare and how they view reform. And so some of the things that they're really looking for and that they're hoping that will happen, there is a sense among many states that the federal government has sort of forgotten them. And I think that comes from two reasons. States, of course, have the challenge. They have to balance their budget at the end of every fiscal year. And as we know, the federal government does not. So that creates a tension for a lot of the governors who are faced with very difficult decisions and not a whole lot of levers to pull. The other challenge that states are facing is that much of what's happening now is being supported by incredible amounts of funding. But the states have to look ahead and see, how are we going to support that down the road? Health information exchange and EMR is a great example. There's a lot of money there to help providers set these up. But what's the sustainable model? How can the physician's practice or the hospital maintain this after the federal funding is gone? There's a lot of stimulus money and money coming in for Medicaid, but what happens when that goes away? Finding what the solution is there, what the model is going to challenge a lot of the assumptions that we've made historically about how healthcare is delivered, particularly for lower income populations. Commonwealth care was often very controversial because the model was trying to take Medicaid and sort of integrate it with a commercial model where appropriate. We did have copays for higher income people that are similar to that they would pay if they had commercial insurance. We did have premiums. And a lot of the assumptions that were made initially, one of the things that I worried most about is that when we started charging premiums, people would pay them only when they needed it and then they would drop out and we would have a big risk issue. That's really ultimately what undid TennCare, is that it was only the sick people who were in the pool. It turned out that ComCare had less than a 1% rate of unenrollment because of failure to pay. I was wrong in my assumption. I was actually kind of ashamed of myself as I started understanding what was happening with the program. We really have to challenge, and there are some states that frankly have done this better than others, in challenging assumptions about what works and what's not going to work. Because this is the time, there is an environment that has been created that's really going to allow us to do some innovative and interesting things. And it's a moment in time. I think that a lot of states are going to work very hard to take advantage of that. So some of the things that states need also to be successful, interagency collaboration. I have to say that the thing that concerns me most about this federal legislation is that it was not passed with any sort of collaborative spirit. Massachusetts was successful because there was a very strong coalition that started from the beginning. Folks at this table can tell you we had some really, really challenging, difficult times that we went through. We had places where we disagreed passionately with each other privately. We had some very public debates. But at the end, the coalition held. And I think Brian will agree with me, it has been imperative to our success. I am concerned about something as large as federal national reform starting from a place where there is so little consensus. But that said, within states, one of the biggest challenges they face is interagency collaboration. It was not as big a challenge as Massachusetts because Medicaid and the Division of Healthcare Finance and Policy and the Department of Revenue and all the technical people were committed to this from the beginning. But as you think about how to kind of pull the pieces together, recognizing that in some states they're not only geographically disparate, but they have very different infrastructure, that's going to be a challenge for states, and I'm not sure it's one that the federal government recognizes. In many ways, it's a state's issue to resolve. But for us, that was a big piece of why we were successful. So last thing that the states need, they're asking for flexibility. Medicaid right now is very constrained by a rule called MOE, it's maintenance of effort. And the feds basically said, we're going to give you a lot of funding, but you have to make sure that you continue to cover people. And in doing so, they can't make changes to eligibility rules and benefits. That has created a lot of challenges for the states because in many instances where you would go to try to relieve Medicaid cost is in sort of tinkering with either the benefit package or who you covered, and that's not possible right now. I was very disappointed to learn yesterday that Arizona is the first state that's actually going to make a big drop in their CHIP program. They're going to lose millions of dollars, probably billions of dollars. Now, I'm hoping that they're doing that to draw attention to the problem, and I think that may be the case because they're focusing on kids. But the government's, I think, unintentionally created a paradigm where you either have to leave things alone or you have to drop it altogether. And I hope that that can change a little bit over time. So finally, what's going to happen at the state level with this sort of federal umbrella? There's going to be a Medicaid expansion, and that's probably going to be upwards of 16 million people. That's a really big deal. Most states' Medicaid programs, if you set the financiers aside, are really straining already. You've had a lot of people